All right, well, thanks, Peter. Thanks, SAEM, for this opportunity. So despite, as Phil said, several failures, I still think we have a lot of work to do. And Peter highlighted some of the things we're going to do. I'm going to talk about one specific trial and maybe acknowledge that Phil's early data needs to be validated in a prospective study as well. So those are my disclosures. So I want to talk, like I said, about one of the unmet needs in acute heart failure therapy. I don't think we've figured out what we should be doing in the ER from the time zero perspective. And I think the prior data that's out there, especially stuff from the NHLBI Heart Failure Network, will really inform our subsequent trial design to probably test this in an ED-based study. So I would suggest we've actually come a long ways in the last probably 6, 8, 10 years. The new normal in heart failure, we're pretty darn good at diagnosis. Slides used to say 80% diagnosed correctly in the ER. I think we're much better at that now. With the introduction of lung and cardiac ultrasound at the bedside, chest x-ray, throw in a physical exam finding and natriuretic peptides to sort of exclude heart failure. As Anna Marie said, the Jen Martindale meta-analysis really shows that with a couple of key findings, our diagnostic accuracy is actually quite high. Endpoints of therapy, Peter has discussed whether we use lung ultrasound. We use something to identify underlying congestion better than just are you short of breath, because guess what? Everybody gets better in the hospital. Whether it's placebo or not, people feel great sitting in bed, and yet they go home and come back 5 days later because there's a bunch of congestion that we missed. So to get at this congestion idea, I think we need to talk a little bit about ED therapy. What kind of therapy, how much, and how often? So the one plug that I would say from Phil's perspective, he didn't toot his horn enough. I mean, he really has changed the dynamics regarding hypertensive heart failure. I really think the treatment is non-invasive ventilation, nitroglycerin and or ACE inhibitors. Phil has some good preliminary data. We need a prospective trial to study this early. It would be a little bit tricky. These patients are kind of sick, but we've heard a lot about pragmatic and crossover trials. This is just begging to be studied. But that's not what I'm going to talk about today. I'm going to talk about the best approach, I think, from my perspective, to be studied from a volume removal perspective. So there has been a ton of interest in this. If you look at the last 10 years of studies funded by the Heart Failure Network, DOSE, studied by Michael Felker, published in the New England Journal, sort of laid the groundwork for inpatient practice, right? 2.5 times your home dose of Lasix. Probably was a little bit better than the evidence in the House of God, which was, what, age and renal function, I think. The problem with this study is it allowed physicians to muck up the study. They allowed you to down-titrate the medication at 48 hours, so it never really stayed on the high-dose therapy. They got 2 days of high-dose therapy and then 5 days of regular stuff, and everybody regressed to the mean. CARES, really interesting, a very aggressive trial looking at persistent heart failure with probably the most aggressive diuretic pathway ever developed, and that may be why the study was neutral, quite honestly. They hammered the kidneys with diuretics, and they compared this to ultrafiltration and found there was no difference in outcome. ROSE actually looked at a little bit different population. This was a group of patients who were sick with renal dysfunction in the hospital, who weren't diuresing as expected, and got this stratified randomization to dopamine or serotype. Again, another neutral study looking at a small subset of patients that we typically don't take care of. This is typically a 48-hour in the hospital study. But I think a lot of things that we learn from this, approaches and outcomes and endpoints, can be used to design the next study. So what should we do in the ED? Should we think about renal function? It makes a difference. Home dose, their blood pressure, how sick are they? I think the answer is yes, 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 and yes. But how do we do it? It's going to be key. So this is Felker's DOSE trial, and I'm not going to spend a long time. It's been published a while ago. But basically it said we could be aggressive early with diuretics. And those patients who, as Phil would say, have cardiac failure and not hypertensive heart failure, an aggressive dose of diuretic, really I use the 2 to 2.5 times home dose is what should be done probably. The risk of renal dysfunction is actually very small. And actually, what does a bump in your creatinine in the hospital mean? I think it actually means that you're getting better, and it's what we should be targeting, rather than saying, okay, they have acute heart failure and acute kidney injury, I can't give them diuretics. It's actually quite the opposite. They get better when you give them diuretics. In a subsequent study by Meredith Briscoe, they actually looked at if your creatinine changed in the hospital. So if your creatinine got slightly worse, it went from 1.4, keeping count here, 1.4 to 1.7, let's say. You did better, your chance of getting readmitted or dying in the next 30 days, than the person who you were patting yourself on the back for. My creatinine went from 1.7 to 1.4. That person actually came back sooner. Why? because you're not getting to dry. You're not drying them out, and they leave the hospital, and they come back readmitted in 10 days with congestion. So our markers don't work, and we're scared of stuff like renal function. I think it's because we need a better target. So ironically, worsening renal function at 72 hours suggests a better prognosis than improved renal function in the hospital. So what about time? Does time matter? Well, I'd like it to say it's like the clot Phil talked about, and time to matters, door to balloon. This is not ACS. This is heart failure, and the data's all over the place. Alan-Mazel's study suggested time did matter. Earlier diuretics was decreased in-hospital mortality. The Matsu study from Jack about a year and a half ago now suggested, again, diuretics in less than 60 minutes was much better than diuretics greater than 60 minutes from a mortality perspective. However, this was just published in JACC Heart Failure suggesting that time didn't matter. This is a study from Japan, large cohort study, but really didn't make a difference whether you got Lasix early or Lasix later. What's the problem? There's a lot of them, unfortunately. There's not been an ED-based randomized study. These are all cohort studies, right? And there's a lot of pre-hospital contamination, a lot of comorbidity contamination. And importantly, some of the studies that we mentioned earlier, Rose and Caress, actually wait for badness to happen rather than trying to prevent badness. So they wait for renal dysfunction. They wait for worsening heart failure before you randomize the patient. Why don't we do something that actually prevents all that? So again, no good targets. Dyspnea, weight loss, and urine output are really tough from a titration perspective. Everybody gets better from a dyspnea perspective. Everybody pees in the bucket. And some of these studies allowed the MD to down-titrate medications, which I think is a problem because we don't know how to down-titrate based on symptoms alone. So I think the unmet need, I would suggest, is an objective target for diuresis and using this in an ED-based randomized study. And I would think that we need to figure out how we target our therapy based on what's the best target for volume removal. So how do we do this? Dyspnea, not very good. Everybody feels better at the end of the stay. 50% get readmitted because they're still wet, and we can't measure it. Urine output, it's not predictive of safe discharge. There's no strong correlation with body weight change. And body weight doesn't correlate with symptoms or readmission either. So we keep chasing our tail. Which one are we going to pick? We're going to pick the one that makes us feel good. I improved X, Mrs. Smith can now go home. I think that's the wrong approach. So what's our real goal? I think Jeff Testani has done a ton of this work. I'm stealing several of his slides. He's cardiologist at Yale and said, you know what, it's not really that you got a lot of volume in the urinal, it's what's in the urinal that really matters. It's diuretic efficiency. If I give you a dose of diuretic and you dump out a bunch of urine that has sodium in it, you're highly efficient, you're responding to your diuretic. And they've looked at this extensively, and I think this is where we need to go. If you have low urine sodium after a diuretic, you have a poor response, and I'll show you in a few slides, you have a poor prognosis from a readmission perspective and from a length of stay perspective. So it's not just urine output, it's what's in the urine that matters. Measure the urine sodium immediately after you give them a diuretic. And this sounds like, oh my God, you're talking about FENAs and internal medicine stuff. I'm like, no, I'll show you how easy this is, okay? It's the one beauty of EPIC, I would say. So don't wait for bad stuff to happen, prevent it from happening, okay? So this is what Jeff looked at. He looked at how much urine did you put out and how did your urine sodium do. So more urine output, more sodium in the urine. Greater weight loss, greater sodium in the urine. But most importantly, if you look at the group of people who are really diuretic efficient, so high amount of urine sodium per the milligram of furosemide you had a much better survival and prognosis than that group of patients who had low sodium in their urine. So it actually correlates with weight loss. It actually correlates with urine output. And guess what? Most importantly, you're really decongested when you pee out a lot of sodium. So it's probably a better marker. So we looked at this in 75 patients. We haven't published this. It's submitted for publication. But 75 ER patients, we gave them 2 times their home dose of diuretic. So we made sure they weren't undertreated. And we measured their urine sodiums at 1, 2, 4, and 6 hours after their dose of diuretic in the ER. And what did we find? We had 15%, so about 10 of our patients developed worsening heart failure during their stay, and worsening heart failure was pretty rigorous. They required an up-titration of their therapy in the hospital for worsening symptoms. In those patients who developed worsening heart failure, their first urine sodium sucked. It was less than 50 and actually less than 35, you need to really worry. So less than 35 millimoles of urine sodium, this person is not responding to what I would suggest is an aggressive dose. We gave up to 200 milligrams of IV furosemide in 1 dose to patients who are on big doses at home. So I don't think we undertreated anybody. So Testani's actually made this easy, and this is where my comment about Epic comes into play. So he said, you know what, I got to make this simple. I want this to be like sliding scale insulin, okay? If you have X urine sodium, I want to be able to put an automated order in that allows the nurse at the bedside to titrate the diuretic. And he came up with some complicated formula based on FENOT, based on maximum urine output, that says, I want to be able to predict your natriuresis at 6 hours based on what your urine sodium is an hour after diuretic. Only thing needed is a spot urine sodium. So his formula works really, really well. You can see after 1 to 2 hours after a diuretic, high correlation with urine sodium output at 6 hours. So I know how much you're going to pee based on the sodium that's in the urine at 1 hour. And more importantly, how do we maximize the sodium in the urine after diuretic? Again, Testani has simplified this. Order a spot urine creatinine and urine sodium 1 to 2 hours after the diuretic's given. Go to cardiorenalresearch.net. This is Jeff's calculator. And you plug in a few things. You can see here, age, weight, height. And guess what? One of the things you plug in there is urine sodium. I have a urine sodium of 107, and this is what my target's going to be at 6 hours. And if you're satisfied with 2 liters of urine and 212 millimoles of sodium, then you just let them continue to diurese. If you get that number back and it says I'm going to put out 300 cc's and 20 millimoles of sodium, I'm going to adjust my diuretic. And he actually has a sliding scale built in the Epic that says my goal is 4 liters at the end of 24 hours, and the nurse titrates a diuretic based on this. So I think we need to do this in the ER. Jeff has done a lot of this in the inpatient setting. Nobody has done this in the ER. And I think we need to look at patients who get a randomized or get a dose of ED diuretic, urine sodium 1 hour later, and then we randomize them to structured therapy. I think you can't put this in against a straw man. You need to pick something, depending on what your hospital does, standard BID or TID dosing, and then put them on the cardiorenalresearch.net protocol, looking at, I'm going to target 4 liters of urine output and X amount of millimoles of sodium in the first 24 hours, and let's go. And every 6 hours, they get a urine sodium checked, and you get redosed based on that. But you don't stop, and you don't let the physician come and say, oh, Mrs. Smith, you're great. JVP's down, your dyspnea is better, stop. No, you stop once you've reached your target output of urine sodium and urine volume. But don't let the physician down-titrate it until you've reached an objective goal of diuresis. Now the question is, what are our endpoints? I think dyspnea, unfortunately, everybody gets better. We probably need to look at something more. Worsening heart failure, probably heart failure readmissions. If you're decongested appropriately, you're going to come back last. And then CV mortality. The protocol endpoints, I think, obviously if you're discharged from the hospital, you're going to stop the protocol, but things to think about strongly is symptomatic hypotension and worsening renal failure, but define it appropriately. You saw the slide I put up earlier from Meredith Briscoe. If your creatinine bumps and you're getting better, it's actually a good thing. If your creatinine bumps and you've stopped peeing or you're getting worse, it's a bad thing, and that's worsening renal function, and it needs to be aggressively treated. I think that's it. So, ED-based diuretic therapy, it's poorly defined currently. I think a lot of things matter. Timing, dose, duration, all should be answered. My suggestion is, it sounds very internal medicine-ish and geeky, but urine sodium seems to be where the money is. It's much better than our, Mrs. Smith is getting better sort of thing. And what's in the urine really does matter. It's not just volume, it's how much sodium relative to that volume. And I think we need to start this in the ED. The more you can leverage this up front, shaving days of length to stay off on the back end, but most importantly, they're adequately diuresed. I think we really need to do this through hospitalization. And it goes without saying, it requires a tremendous amount of collaboration with your inpatient colleagues. All right, thank you.